Hello, good evening, madam.
Hello, sir. Good evening.
Please proceed, madam.
Sure, sir. Hello, everyone. Welcome to Tawhid Foundation for Allied Healthcare Sciences, Bangalore. Today's class is about spirochetes. So, before we begin, let's first understand what spirochetes are and why they are important in microbiology and medicines. So, spirochetes are a unique group of bacteria characterized by their spiral or corkscrew shape. Unlike most bacteria that move with ordinary flagella, spirochetes use axial filaments, which means endoflagella, located beneath their outer shell. Their special type of motility allows them to move efficiently through viscous environment like mucus. Motility allows them to move connective tissues and even within blood vessels. So pathogens that cause major human diseases are Trypanoma palladium, Borrelia species, and Leptospira. So Trypanoma palladium, it causes syphilis. It is still a global health problem. Borrelia species, it is responsible for Lyme disease and relapsing fever, and Leptospira interrogens, which causes leptospirosis, a serious zoonotic disease often linked to floods and contaminated water. So, we study spirochetes because their infections are chronic, systemic, and often difficult to diagnose. So, many of these organisms are too thin to be seen in routine stains and cannot be cultured easily. So, diagnosis relies on special microscopy and serological tests. So, clinically, they cause diseases that can mimic many other conditions, earning syphilis the title of the great imitator. So, we'll start with spirochetes. Spirochetes are a unique group of bacteria that are thin, flexible, and spiral shaped. Their morphology sets them apart from other bacteria because they resemble tightly coiled springs or corkscrews. A key feature is their motility, which is achieved through axial filaments, also known as endoflagella. Unlike external flagella, these filaments are located beneath the outer shell, allowing the organism to twist and move in a corkscrew fashion. So this movement is highly efficient in viscous environment such as mucus or tissue, which explains how they penetrate host tissue so effectively. So these three spirochetes, trypanoma, which causes syphilis, Borrelia, it can cause Lyme disease or relapsing fever, and Leptospira, which causes leptospirosis. So we'll move further. Trypanoma palladium. Trypanoma palladium is a only human pathogen and has a known animal reservoir. Transmission primarily occurs through direct contact with infections, lesions that contain spirochetes. These lesions are often found on the genitalia, mouth, or anus during sexual contact. Importantly, the infection can also be passed from mother to fetus across the placenta, leading to congenital syphilis, especially after the third month of pregnancy. Another potential route is via blood transfusion. If the donor blood is collected during early syphilis, globally, syphilis occurs everywhere and its incidence is unfortunately increasing due to inadequate safe sex practices. So, this Trypanoma palladium is thin, tightly coiled spirochetes with pointed, straight ends. It is too thin to be seen with gram or Giemsa stain. Its motility is through undulation of axial filament that lie under the outer shell. Trypanoma palladium has not been grown on bacteriologic or in any cell culture medium. So, how it is transmitted? This Trypanoma palladium, a striking feature is that it produces no classical toxins or enzyme. Its pathogenesis is linked to its ability to infect the endothelium of small blood vessels. from spirochetes containing lesions of skin or mucous membrane, which is genitalia, mouth, or anus of an infected person to other person by intimate contact. So from pregnant woman, it can transfer to fetus, blood transfusions collected during early syphilis. Trypanosoma planidium is only human organisms and syphilis occurs worldwide. Its incidence is increasing day by day. Its pathogenicity and immunity. So its pathogenicity is linked to its ability to infect the endothelium of small blood vessels, leading to endocarditis. The tissue damage and lesions we observe in syphilis are mainly due to the host immune response, not direct bacterial toxin. Although antibodies are produced, they are insufficient to halt disease progression, which explains why patients treated for early syphilis can get reinfected. However, patients with late syphilis develop partial resistance to reinfection. This will incomplete immunity, which highlights the chronic and relapsing nature of the disease. So, the immunity and pathogenesis of Trypanosoma pallidum will produce no important toxins or enzymes. It often infects the endothelium of small blood vessels, which causes endocarditis. This tissue destruction and lesion will be observed in syphilis, primarily the consequence of patient's immune response to infection. It all depends upon patient's immune response, how they'll react to the infections. Immunity to syphilis is incomplete. Its antibodies to the organisms are produced, but it will not stop the progression of the disease. Patients with early syphilis have been treated and can contact with syphilis again. So, patients with late syphilis are relatively resistant to reinfection occurrence. Its clinical features: primary syphilis. So, the first stage of syphilis is known as the primary syphilis. This is the first stage of syphilis. After infections, spirochetes multiply at the site of entry, and within 2 to 10 weeks, a characteristic painless ulcer called a cancre appears. This lesion is highly infectious but not painful, which is why patients often ignore it. The ulcer heals spontaneously after a few weeks, but that does not mean the infection is cleared. In fact, by this time, the spirochetes have already spread wildly through the bloodstream, setting the stage for systemic infection. So, this Trypanosoma pallidum causes syphilis and has three phases: primary phase, secondary, and tertiary phases. So, spirochetes will multiply at the site of inoculation, and a local non-tender ulcer, which is known as cancre, usually forms after 2 to 10 weeks of infection. The ulcer will heal spontaneously, but these spirochetes spread widely through the bloodstream bacteremia to many organs. So, secondary syphilis, 1 to 3 months after the primary cancer heals, secondary syphilis developed. This stage is marked by widespread dissemination of spirochetes. So, the most characteristic features is a maculopapular rash, particularly noticeable on the palms and soles. A very high yield clinical sign. So patients may also develop moist lesions on skin and mucous membranes. So on the genitals, these lesions appear as condylomata later, which are highly infectious. Along with skin manifestations, patient will also experience constitutional symptoms like fever, malaise, headache, weight loss, muscle pains, and generalized lymphadenopathy. Secondary lesions eventually heal spontaneously, but the disease enters a latent stage if it is untreated. So, in secondary syphilis, after 1 to 3 months later, the lesions of this secondary syphilis may occur, but maculopapular rash on the palms and sole, as you can see in these images, Moist papules on skin and mucous membranes as well. Moist lesions on the genitals, which is known as condylomata lata. The lesions are rich in spirochetes and are highly infectious, but they also heal spontaneously. But if it is healed, it doesn't mean that spirochetes is not present. Constitutional symptoms, all these symptoms will be visible if the patient is infected. Low grade fever, malaise, anorexia, weight loss, headache, all these symptoms. Latent syphilis. Latent syphilis is a clinically silent phase. About one third of untreated primary and secondary cases progress into this stage. Patients will show no visible lesions, but serological tests remain positive, indicating the persistence of infection. Early latent syphilis within 1 or 2 years, it may still relapse into secondary symptoms and patients remain infectious. In contrast, late latent syphilis may last for many years, during which patients are asymptomatic and generally non-infectious except for vertical transmission to a fetus. So after one third of early syphilis, which is primary and secondary cases, it will cure themselves without any treatment. Latent syphilis, it will occur in one third of early syphilis cases. Here in this stage, no lesions will appear, but positive serological tests indicate continuing infections. So during early stages, that means around 1 or 2 years, the symptoms of 20 syphilis can reappear and patients can get reinfected. In the late period can last for many years. In this, no symptoms occurs and patients are not infectious. Last is tertiary syphilis. Tertiary syphilis develops in about one third of untreated cases, usually 3 to 10 years after the initial infection. It is characterized by chronic inflammation that can affect virtually any organ. The hallmark lesions is the gammas. Here, as you can see, gammas are granulomatous lesions that may appear in the skin, bones, or other tissues. Ocular involvement may lead to blindness, while cardiovascular lesions often involve the aorta and valves, causing aneurysm or regurgitation. Neurosyphilis may damage the spinal cord and brain, which will lead to paralysis and dementia. Interestingly, trypanomas are rarely found in tertiary lesions, making them more of an immune mediated process. So, what happened in tertiary syphilis? It will occur in the remaining one third of early syphilis cases. After 3 to 10 years, it will develop primary infections. A diffuse chronic inflammation affect most of the organs or tissues. Gammas, which is granulomatous lesions, it can be found in several parts of the body, that is bones, legs, skins, and other tissues. Lesions in the eyes can lead to blindness. Small lesion, as I mentioned in this slide, as you can see, lesions in the eyes which can lead to blindness. Lesions in the cardiovascular system, that is heart, can lead to damage aortic valves. Neurosyphilis, it may lead to damage the spinal cord, and the patient will get paralysis. In tertiary lesions, trypanomas are rarely seen. Congenital syphilis. So congenital syphilis occurs when the spirochetes cross the placenta, typically after the third month of pregnancy. This can cause severe consequences for the fetus, including stillbirth, neonatal death, or a wide range of deformities, such as Hutchelton's teeth, saddle nodes, and intestinal keratitis. Early recognition and treatment during pregnancy are critical to prevent transmission. So in this slide, I just put this image of congenital syphilis. Rest, many are there, that is Hutchinson's death, saddle nose, and intestinal keratitis. So as you can see here in congenital syphilis, how patient's cornea was before and after. So the organism is transmitted across the placenta from mother to fetus, typically after the third month of pregnancy. Laboratory diagnosis and treatment. So diagnosis begins with microscopy using dark field examination or fluorescent antibody staining for direct detection. Serological tests are divided into two categories, that is non-specific tests such as VDRL and RPR, which detects region antibodies against cardiolipin but may give false positives, and specific tests like FTA-ABS and TPHA, which use trypanosome antigens and remain positive for life. So both the categories are complementary and often used together. The treatment of choice for all the stages of syphilis is penicillin, making it one of the most effective antimicrobial therapies in medicine. So laboratory diagnosis can be done through microscopy, dark field microscopy, or fluorescent antibody test. Serological tests also include, and some no specific tests as well. So here in this picture, you can see dark field microscopy image as well as fluorescent antibody test. And fluorescent, you can see some neon greenish color images of this Trypanosoma palladium. So further continuation of this laboratory diagnosis, non-specific serological tests also include. It involves the use of non-trypanomal antigens. It extracts of normal mammalian tissues. Example is cardiolipin from beef heart, VDRL, RPR. It also gives false positive reactions. Specific serological test, it involves the use of trypanomal antigens and therefore are more specific. It will remain positive for life treatment, and penicillin is the drug of choice for all the three stages of syphilis, that is primary, secondary, and tertiary. As you can see the images of VDRL test and RPR test. Here it is showing non-reactive reaction and reactive reaction. In non-reactive, it is merged properly, and in reactive, as you can see, some agglutination. Next is Borrelia. So Borrelia species are unique spirochetes because they stain poorly with the gram stain. They do not fit nearly into the categories of either gram positive or gram negative, but their cell envelope structures more closely resembles gram negative bacteria with an outer membrane. They are large than other spirochetes, measuring about 0.2 to 0.5 μm in width and up to 30 μm in length. Unlike Trypanosoma and Leptospira, Borrelia stain well with aniline dyes such as Giemsa and bright stains, which makes them visible in standard blood smears, particularly in patients with relapsing fever. These features is highly useful for direct microscopic diagnosis. So Borrelia is nothing but the member of genus Borrelia. It causes two important human diseases, Lyme diseases and relapsing fever. So human Lyme diseases is called as Lyme borreliosis. It is caused by Borrelia burgdorferi and Borrelia gargini. Borrelia as afzeli also. Transmission is through tick bite. Physiology and structure of Borrelia. So Borrelia are microaerophilic organisms requiring a reduced oxygen environment to grow, and they have complex nutritional requirements, making laboratory culture extremely difficult. Even when cultured successfully, their generation time is very long, up to 18 hours or more. So because of these limitations, culture is not practical diagnostic tool. Instead, clinicians rely on serology for Lyme disease and direct microscopy for relapsing fever. This distinction is important to remember for exam as well as clinical practices. So, physiology and structure of Borrelia. Here, member of the genus Borrelia, it will stain poorly with gram stain reagents. It is neither considered as gram positive or gram negative organism, but it has an outer membrane similar to gram negative bacteria. It is larger than other spirochetes, that is Trypanosoma palladium, and one more. So its size is ranges between zero point 0.2 to zero point 0.5 into 8 to 30 μm. It stained well with aniline dyes, that is giemsa or right stain. It can be easily seen by either light microscopy when present in smear or peripheral blood from patients with relapsing fever. Continuation of physiology. So, Borrelia species do not produce any known toxins. Their virulence lies in their ability to evade the immune system. In relapsing fever, the hallmark clinical feature is the cycle of fever and afebrile periods. This occurs because Borrelia are capable of antigenic variation. They repeatedly change the proteins on their surface, allowing them to escape the host antibody response. So each time the immune system mounts a response, the bacteria will alter their surface antigens, leading to another febrile. So this antigen variation is the reason for the recurrent nature of relapsing fever. So, Borrelia are microaerophilic and have complex nutritional needs, which makes them difficult to grow in the laboratory. These species have been successfully cultured throughout the generational times of 18 hours or longer than that. Because culture is generally unsuccessful, diagnosis of this disease caused by Borrelia is by serology, that is Lyme's disease, or microscopy relapsing fever. Borrelia, so pathogenesis of this Borrelia, it will not produce any recognized toxin and it will remove rapidly when a specific antibody response is mounted. So the period is febrile and afebrile cycle of this relapsing fever, which will result from the ability of Borrelia to undergo antigenic variation. Next is epidemiology. So epidemic relapsing fever is caused by Borrelia recurrentis and is transmitted exclusively by the human body louse. Humans are the only known reservoir. Transmission occurs when lice feeding on infected individuals are crushed, allowing Borrelia to enter through the skin. So this disease is associated with poor hygiene conditions, overcrowding, and disasters such as wars or refugee crisis. Geographically, epidemic relapsing fever is still found in parts of Africa, particularly in Ethiopia, Eritrea, Somalia, and Sudan. This is the epidemiology. First, epidemiology is divided into two parts. First, A epidemiology, which is showing relapsing fever, which is caused by Borrelia recurrentis. It is transmitted by human louse. Humans are the only reservoir in this diseases. Lice will get infected after feeding on an infected person, and disseminated disease is not believed to occur in lice. However, humans infection occur when the lice are crushed during feeding. This infection is caused in crowded place, unhygiene conditions, and it is found generally in these countries. Next is B part, which is endemic relaxing fever continuation. It is caused, so the most reliable diagnostic of this relapsing fever is caused by multiple Borrelia species, up to 15 different ones. The disease is transmitted by soft ticks belonging to the genus Ornithodorus. These ticks act as both vector and reservoir, along with rodents and small mammals. Unlike lice, Infected ticks can develop disseminated infections, which means they remain carriers for life. Human infection occurs when ticks bite and contaminate the wound with Borrelia in their saliva or feces. So, this disease is distributed worldwide wherever ornithodores ticks are present, and it is considered a zoonotic infection. So it is caused by as many as 15 species and transmitted by soft ticks, which is known as Ornithodorus species. Rodents, small mammals, and soft ticks are act as the main reservoir, and it is also known as zoonotic diseases. Unlike the louse-borne infection, the Borrelia will cause endemic disease, which is produced through disseminated infections in ticks, and the ticks will contaminate the bite wound with Borrelia present in their saliva or feces of ticks. This tick-borne disease is found worldwide, corresponding to the distribution of this tick or Ornithodorus species. So, as you can see in this table, that it is divided into three parts: infection, reservoirs, and vector. Infection is relapsing fever epidemic, louse-borne, relapsing fever epidemic, tick-borne, and Lyme disease. So reservoir for louse-borne is human and vector is body louse, and for tick-borne, rodents and softings act as a reservoir, vector is soft tick, and for Lyme disease, rodents include reservoirs include rodents, deer, domestic pets, and heart tick. So these table will explain the infection, reservoir, and vector of this Borrelia disease. Laboratory diagnosis of a relapsing fever through microscopy. The most reliable diagnostic method for relapsing fever is microscopy. A blood specimen is collected during a febrile episode when Borrelia are circulating in high numbers. Giemsa or white stained blood films reveal the spirochetes clearly. This method is highly sensitive and gives rapid results, with organisms detected in more than 70% of cases. For Lyme disease, however, diagnosis relies on serological tests such as ELISA, followed by confirmatory Western blot, since Borrelia are not easily visualized in routine samples. So, specimen will include blood sample, Giemsa stain or right stain blood film. It is most sensitive method for diagnosing relaxin fever, with smear positive for exam organisms in more than 70% of patients. Treatment, it is most effective with tetracyclines or penicillin, and vaccine is not discovered yet. As you can see in this image, so this slide typically shows a Giemsa stained blood smear from a patient with relapsing fever. The Borrelia organisms are visible as long, wavy spirochetes scattered among red blood cells, which highlight to students that this is a classic diagnostic image and may be shown in exam or practicals to understand them. Seeing Borrelia in blood film is highly characteristic of relapsing fever and demonstrate the advantages of microscopy in diagnosing the disease. So this is the microscopic image of Borrelia organism in the blood of a patient with endemic relapsing fever. Treatment. So both Lyme disease and relapsing fever respond well to tetracycline or penicillin. Early treatment is essential to prevent complications, especially in Lyme disease, where untreated infections can progress to arthritis, neurological disease, or carditis. Unfortunately, there is no vaccine is currently available for either Lyme disease or relapsing fever. So prevention depends on vector control and protective measures against tick or louse exposure. Next is leptospira. So, Leptospira are very delicate, actively motile spirochetes with closely wound spirals and characteristic hook ends, often described as resembling umbrella handles or question marks, because they are extremely thin. They cannot be visualized under the light microscope in routine staining. Instead, they require dark field illumination or electron microscopy. Some species are saprophyte while others are pathogenic. The first recorded human leptospiral disease was spirochetal jaundice, described by Weil in early 1886 and later in 1907. Stimson observed these organisms in stained kidney sections. So, today, leprospirosis is recognized as an important zoonotic disease across the world. So, interaction, it is actively motile and delicate spirochetes, one of the species of spirochete. It has large number of closely wounded spirals with hooked ends. It is too thin to be seen under light microscope. Leptospira are saprophytic and some are parasitic as well. First human leptospiral disease is introduced as spirochetal jaundice. Weil discovered it in early 1886. Stimson in 1907 it observed slender spirochetes in silver stained section of kidney. So Leptospira are slender, flexible helical rods that measures around 6 to 20 mm in length and only about 0.1 mm in thickness. Their most distinguishing feature is their hooked ends, which make them look like a question mark under the microscope. They stain poorly with common aniline dyes that but can be demonstrated using this GIMSA or silver impregnation methods in living condition, that is dark field microscopy method, to visualize their characteristic motility. Cultural characteristics of Leptospirea. It required enriched culture condition because of their fastidious growth requirements. They can grow in media containing rabbit serum, such as Korthoff's, Stewart's, and Fletcher's media. Today, the semi-synthetic EMJH medium, that is Allen Gosson McCullough Johnson Harris medium, that is EMJH, is most commonly used. They are aerobic to microaerophilic organism and their growth is very slow and patience is needed in the laboratory to successfully culture them. So in semi-solid media, leptospira show characteristic growth a few millimeters below the surface, which is helpful diagnostic clue. The optimum temperature for growth is between 25 to 30 degrees Celsius and the ideal pH is around 7.2 to 7.5. Their generation time is relatively slow, up to 12 to 16 hours, which explain why cultures take a long time to yield visible growth. Resistance. Leptospira are fragile organisms that are easily destroyed by environmental factors. They are killed within 10 minutes at 50 degrees Celsius and in just 10 seconds at 60 degrees Celsius. They are also destroyed by acidic conditions, that is bile and chlorine. So in just 10 seconds, it will be destroyed. However, in moist environment with a neutral pH of around 6.8 till 8, they can survive for several days. This explains their persistence in contaminated water sources and their transmission through floods or stagnant water. Leptospira classification. It is classified into two species. So pathogenic leptospirus are grouped under Leptospira interrogens, which includes 22 serotypes and over 200 22 serogroups and 200 serotypes. Example include Asterohemorrhagic canicola pyogenes, autumnalis, australis, and pomona. So, non-pathogenic species such as Leptospira biflexa are saprophytic and found in surface water. Classification is based on surface antigen with serotyping performed using agglutination and cross-absorption reaction. Its antigenic properties. So Leptospira exhibit so first, this Leptospira biflexa, it contain its saprophytic leptospirides, which is found in surface of water. This serogroup and serotype of Leptospira classification is based on the surface antigen, and determination of the serotype will be based on agglutination and cross-absorption reaction. Antigenic properties of Leptospira exhibit antigenic cross reaction, which can complicate serological diagnosis. Serotype determination is usually done by agglutination test using immune rabbit sera or monoclonal antibodies. Molecular methods such as restriction endonuclease analysis and DNA pairing are also used to differentiate strains. Toxin production. Leptospira produce several virulence factors. Their lipopolysaccharide LPS. It functions as an endotoxin but has a relatively low potency compared to gram-negative bacteria. Interestingly, leptospiral LPS signals through TLR2 instead of the usual TLR4 pathway. They also produce hemolysins, phospholipase C, sphingomyelinase, and other cytotoxins that damage host cells. For example, long chain fatty acid can insert into host membranes, disrupting their integrity and causing cell lysis. So, lipopolysaccharides. Here, as you can see, Leptospira are primarily zoonotic pathogens in their natural reservoir host, such as rodents and domestic animals. Infections are asymptomatic. So for lipopolysaccharide, it is endotoxic and its potency is very low. It will signal via TLR2. The following structure of this lipid determines to be recognized via TLR2 and uniphosphorylated diglucosamine backbone 5-acyl chain, that is 1622 acyl chain length. So for cytotoxin, hexadecinoic acid, which means a long chain of fatty acid, it will gets intercalated into host cell membrane in place of normally occurring fatty acid, and it is disturbed membrane permeability, which will lead to cell lysis. Pathogenicity and transmission. So, as Leptospira are primarily zoonotic pathogen in their natural reservoir hosts such as rodents and domestic animals, infections are asymptomatic. However, the organisms are shed in urine, which contaminates soil and water. Humans acquire infection when exposed to contaminated water, especially through skin abrasions or mucosal surfaces of the mouth, nose, or conjunctiva. Rarely, ingestion and inhalation can also serve as routes. After entry, leptospirosis disseminate rapidly throughout the body because of their motility and ability to evade phagocytosis. So, this leptospira, it is a natural reservoir, which means it is asymptomatic in nature. It is zoonotic disease. Urine is of this carrier animal will contaminate the water bodies, and through and water body it enters through cuts and abrasions on the skin or through contact. Mucosa of mouth, nose, and conjunctiva. Incubation period in 10 days, that means 2 to 26 days. So entry through the skin, two types, that is intact skin and cuts or abrasions. Intact skin, it can cause hyaluronase, chemotaxis towards fatty acid. For cuts and abrasions, chemotaxis towards hemoglobin. So these two majority of cases is seen about 90% in individuals. Other routes is ingestion, mucous membrane, and inhalation. Dissemination, failure to localize and proliferate at the site of infection, and motility of this leptospirosis, more motile in viscous environment of body fluids. Survival and growth. So outer envelope of this leptospira, it is antiphagocytic component which escapes phagocytosis unless it is opsonized, and it also induces apoptosis of macrophages via toll-like receptors too. Clinical features, leptospirosis has two broad clinical types. The majority of cases is 90%, that is an enteric, are which is anecteric and presenting as a mild flu-like illness. Around 10% will develop esoteric leptospirosis, which is also known as Wales syndrome, which carries a high mortality rate. Clinically, leptospirosis often show two phases: the septemic phase, during which leptospira are present in the blood, and followed by the immune phase characterized by antibody formation and tissue damage. Key features include fever, malaria, headache, jaundice, renal impairment, meningitis, hemorrhagic tendency, and sometimes pulmonary manifestations. So these immune phases, three types: hepatorenal manifestation, hemorrhagic manifestation, and aseptic meningitis. These are the symptoms. Fever, irregular subsides in 10 days. Jaundice, 10 to percent of cases in second or third day. Purpuric hemorrhage, skin and mucosa. Severe cases include acute onset, rigor, vomiting, headache, intense infection of the eyes. So as you can see in this image, symptoms and signs of leptospirosis for acute phase and for immune phase. For acute phase, normal mild symptoms: fever and headache, conjunctival suffusion, jaundice and photopia, cough, abdominal pain and vomiting, pancreatitis, all this, muscle pain, skin rash, all this will show acute phase. And for immune phase, meningitis, lung bleeding, myocarditis, it is seen very rarely. Liver failure, stomach bleeding, kidney failure, melena, and bruises. All over the body, you'll see small red patches of bruises. Icteric leptospirosis, that is Wales syndrome. Wales syndrome is the severe ecteric form of leptospirosis and occurs in about 10% of cases. It is characterized by jaundice, renal failure, hemorrhages, and high mortality rate, that is 5 to 50%. The septicemia and immune phases are not distinct in these patients. The disease progresses rapidly, and death often results from multi-organ failure or severe pulmonary hemorrhage, which will lead to acute respiratory distress, that is ARDS. CNS manifestation, there is two types of manifestation. First is CNS and pulmonary. So for CNS, involvement usually appears as aseptic meningitis, which is not due to direct invasions but immune complex mediated inflammation. Pulmonary involvement is particularly severe, marked by vasculitis and massive hemorrhage throughout the respiratory tract. Hypoxia worsens vascular damage, and in severe cases, patient may progress to ARDS. These complications account for the high mortality seen in Wales syndrome. So for CNS, aseptic meningitis, it is not due to direct bacterial infections, and immune complex is mediated for CNS. For pulmonary vasculitis, it is profuse pulmonary hemorrhage, that means throughout respiratory tract. Resultant hypoxia worsen vascular damage and it may progress to acute respiratory disease syndrome. Laboratory diagnosis depends on the phase of illness. In the first week, that is septicemia phase, leptospirosis can be detected in whole blood or serum. After the first week, they disappear from blood but may appear in urine, which becomes the specimen of choice for late infection. Dark field microscopy. This dark field microscopy or immunofluorescence may detect leptospirosis, but these methods are not highly practical. Staining techniques. Special staining techniques are required for histological demonstration. This include Fontana staining, where leptospirosis appears brownish black on a yellow background. Modified stainer and stainer technique, where they appear black against yellow or brown tissue, and Levarditis staining, which is Levarditis silver nitrate stain, which highlights spirochetes as black structures. These methods are more useful in research or autopsy samples than routine diagnosis. This is the image of Leptospira showing using Fontana stain at 1000x, as you can see here. Next is examination of urine. So in the second week of illness, leptospirosis may be shed intermittently in the urine. However, they die quickly in acidic condition. So urine must be examined immediately after collection. Centrifugation can concentrate organisms which are thin, which are then observed under dark field microscopy. So this examination in urine, it should after second week and intermediately till 4 weeks. Urine is examined immediately after taking sample because this leptospira will die and lies immediately in acidic urine. This urine can be centrifuged and examined under direct ground microscopy. Culture sample. So for culture, a few drops of patient bloods are inoculated into bottles containing EMJH medium. Cultures are incubated at 37 degrees Celsius for 2 days, then maintained at room temperature for weeks. They are checked every few days by dark field microscopy. This is a time-consuming process, often taking weeks to yield result, but it provides definitive diagnosis. Animal inoculation. So historically, guinea pigs were used as experimental models. Patients' blood was injected intraperitoneally and the animals developed human-like illness with fever, jaundice and hemorrhage symptoms. Leptospirosis could then be demonstrated from peritoneal fluid, though not routinely practiced today, but this method highlights the pathogenic potential of the organisms. Next is serological tests. Serological tests are the mainstay of diagnosis. Antibodies appear by the end of the first week, peak around the fourth week, and then decline. But agglutinins may persist for years. The microscopic agglutination test, that is MAT, is the gold standard for diagnosis. Other tests also include ELISA and rapid serological methods. Molecular diagnosis. So modern methods include nucleic acid hybridization and PCR. PCR is the most valuable because it is rapid, highly sensitive and specific even in previously treated patients. So common gene targets include 16S RNA, rRNA and lipo L32. The disadvantages are cost, complexity, and need for expertise, which limit its use in low resource settings. This is the PCR reaction, as I mentioned earlier. Most valuable test for detection and diagnosis of leptospira, 16S rRNA and lipoprotein 32, which is called as LIP L32 gene. Advantages: it is rapid, highly sensitive, and specific. It can be used to diagnose even in treated case. It will give very quick result. Disadvantages: it is complicated and cost effective. It is expensive, and expertise will be needed to do this test. Leptospirosis in India. Leptospirosis is endemic in many parts of India. The first outbreak was reported in the Andaman Island in 1931. More recent outbreak occurred in Surat, Andaman, Mysore, and Nagpur in 1997. And data from 2018 showed nearly 2,600 suspected cases with a 4% mortality rate, particularly high in Kerala. So, this highlights its continued public health relevance in India, especially during monsoon and flood seasons. So, for treatment, the treatment of leptospirosis include antibiotics such as penicillin and doxycycline, which are highly effective if given early. Severe cases may require intravenous therapy and supportive care. Prevention focuses on rodent control, health education, and chemoprophylaxis. So, for treatment, indication, and regimen, this table is divided into two parts: mild leptospirosis and moderate to severe leptospirosis. For mild, these three drug of choice will be given usually: doxycycline, amoxicillin, and ampicillin. For moderate to severe leptospirosis, penicillin is the drug of choice, and ceftriaxone and cefotaxime. Prevention focuses on rodent control, health education, and chemoprophylaxis in high risk areas. Weekly doses of doxycycline or azithromycin may be used in exposed population, such as food relief workers, flood relief workers. Avoiding contaminated water sources and wearing protective gear are also important preventing these strategies. So, summary of spirochetes. So, this Trypanosoma pallidum causes these spirochetes, which is thin, flexible, spiral shaped bacteria. Its motility is through axial filaments, that is endoflagella. Medically, these three important genera of spirochetes, that is Trypanosoma pallidum, Borrelia, and Leptospira. So for Trypanosoma pallidum, it causes syphilis, which is too thin to be seen in gram stain, and it requires dark field microscopy or special stains. Its transmission is through sexual contact, congenital, transplacental, blood transfusion. Stages of syphilis, there are three stages: primary, secondary, sorry, four stages: latent and tertiary, but it is also considered as three stages only. Primary, it is painless cancre. Secondary, rash on palms and soles will be visible. Condylomata, later it is known as lymphadenopathy. For latent, it is asymptomatic but serology positive. It indicates. For tertiary, it is known as gammas, neurosyphilis, and cardiovascular lesions. Congenital syphilis, it is severe till fetal infection, deformities. Diagnosis shows dark field microscopy, non-specific serological test, that is VDRL, RPR. Specific serological tests include TPHA, FTABS. Treatment, drugs of choice will be given, but the most common one is penicillin. Borrelia, it is larger than Trypanosoma. It is visible in blood smear with Giemsa stain. Diseases, it causes Lyme disease caused by Borrelia burgdorferi complex transmitted by ticks. It can cause relapsing fever as well, epidemic. B. Borrelia recurrentis and louse-borne, and for endemic, it is tick-borne, that is ornithodoros. Pathogenesis is through antigenic variation, which will lead to repeated febrile episodes. Diagnosis is relapsing fever, Lyme disease. For relapsing fever, through microscopy of blood smear, and for Lyme disease, serological tests, which include ELISA and Western blot. Treatment, this drug of choice will be given. For Leptospira, it is thin helical spirochetes with hook ends, which is look like question mark in shape. It is seen by dark field microscopy. Reservoirs is rodents and animals. It is shed in urine. Transmission via contaminated water, and entry is through skin, cuts, or mucosa. Clinical types include anicteric leptospirosis. It is mild and seen in 90% cases. Acteric leptospirosis is known as Wales disease. These are the symptoms caused in ecteric leptospirosis. Diagnosis is through microscopy, serological test, and molecular detection through PCR. Treatment, doxycycline or penicillin will be given to patients. Prevention, rodent control, and chemoprophylaxis, health education is must. So for questions, 3 mark questions. First, define spirochetes and name 3 medically important genera. Second, why can't Trypanosoma palladium be cultured on artificial media? Third, what is the significance of a painless cancre in syphilis? Fourth, mention two non-specific and non-specific and two specific serological tests for syphilis. Fifth, what is condylomata lata and in which stage of syphilis does it occur? Six, name the vector for epidemic relapsing fever and the causative organism. Seventh, what is antigenic variation in Borrelia and why it is important? Eighth, name two culture media used for Leptospira. 9, what are the characteristic morphological features of Leptospira? 10th, write two preventive measures for leptospirosis. For 5 mark question, describe the stages of syphilis with clinical features. Second, explain the pathogenesis and immune response and Trypanosoma palladium infection. Third, write short notes on congenital syphilis. Fourth, discuss the laboratory diagnosis of syphilis. Fifth, explain the epidemiology and pathogenesis of epidemic relapsing fever. Sixth, describe the clinical features and complications of Lyme disease. Seventh, explain the cultural characteristics and laboratory diagnosis of Leptospira. Eighth, write an account on Weil's disease, that is ecteric leptospirosis. Ninth, discuss laboratory diagnostic methods for leptospirosis. And last, 10th, write a short note on prevention and control of leptospirosis in endemic areas. So with this, we covered spirochetes part. I thought we'll finish it off last topic also, but this only took 1 hour. So shall we continue in next class, sir?
Yeah, madam. Please, madam. You can continue. No issue.
Thank you, sir. So only one topic is pending for second year BSc MLT students.
So first year, it's finished, I think, no, madam.
Sorry, sir.
First year, it's over, I think.
First year it's over, and with one more topic is pending for second year. So
Yeah,
after
madam.
that, second year syllabus will be.
Third year, we can start.
Yes, sir.
You have an excellent job, madam. Excellent. Thank you,
Thank you,
madam. Thank you so much.
thank you so much, sir.
Thank you.